Good afternoon. I'm Michelle Young with USF Health, and I'm really excited about today's guest. I've already learned a lot about allergies. Thank you very much, Dr. Tom Casale. I appreciate your time.
Oh, my pleasure. Thank you.
So Dr. Casale is a internal medicine doctor. He focuses on allergy and immunology with USF Health. And we have got a lot to talk about today. This is kind of a really unique one because this is such a unique area where people don't necessarily think that somebody that suffers from allergies might have issues during COVID-19. So let's jump into the questions and we'll go from there. Sound good?
Yep.
Okay, so first, explain to us, let's just get the technical part out of the way. Explain to us what a food allergy is and what are the most common types.
Yeah, food allergy is just an abnormal immunologic response to something that you ingest. And we know that this happens in a lot of people. Up to 32 million Americans are afflicted with food allergies. There are 8 and probably 9 very common food allergies, but the ones that most people recognize would be peanut, tree nut, egg, milk, soy, sesame, um, fish, and shellfish.
Okay, we had some technical difficulties there, but we're
Yep.
back. We're good.
Okay.
So sorry about that. I'm not sure what happened there. So you serve as the chief medical. Let's go back over that. So what the food allergy is, because that might have affected us, and what the most common types are.
Okay. So it's an abnormal response to something that you eat. And there are a lot of different abnormal responses, some of which you would expect. So if you eat something like tuna fish, for example, that's a little bit old, you might get something that's called spermboid poisoning. There's a lot of histamine there. You could get headache, abdominal pain, etc. That's not a food allergy. A food allergy is when you have an actual immunologic response to something that you eat that causes cells in the body to release things like histamine and gives you an acute allergic reaction. Now, we know that in the United States, we have about 32 million people that are afflicted with food allergies. The ones that you hear about most commonly are peanuts, tree nuts, milk, egg, soy, sesame, finfish, and shellfish. But there are other ones, but those make up the majority of the ones that we're really concerned with.
Okay, that makes sense. I did not realize there were 32 million people in the US. That's a lot of
Yeah.
people that suffer from food allergies. So you serve as the Chief Medical Officer for FARE, which stands for Food Allergy Research and Education. Can you explain a little bit about who uses this organization and why?
Well, FARE is the largest patient advocacy group centered on food allergy in the world. And we're also the largest investor in research grants on food allergy. The people that use this the most are the patients because we have a lot of wonderful information about how to deal with your food allergies, how to recognize them, how to distinguish them from adverse reactions. And of course, physicians use it because they point their patients to this site where they might be able to learn more about it.
Well, it sounds like a really good website for people to learn more about food allergies. So I bet you they appreciate your help as the Chief Medical Officer.
Yeah, it's good. And if people are interested, you just have to type in FARE and it pops right up.
Perfect. So you published a paper this week in the Journal of Allergy and Clinical Immunology in Practice, and you're talking about a modified anaphylactic Anaphylaxis.
Relax. Yep.
Anaphylaxis emergency care plan for allergists and their patients to follow. Can we address this revised plan for the COVID-19 pandemic?
Sure. So when you have an allergic reaction to a food, and if it gets very severe where it's life-threatening, we call that anaphylaxis. And what we teach all of our patients is that if you start having symptoms that progress where we think it's going to be either life-threatening or very severe, the first thing you should do is inject yourself with epinephrine. So all of our food allergy patients should have access to self-injected epinephrine devices, these auto-injectors. Now, typically when we have patients do that, we tell them to go to the emergency room because one injection may not be enough, even two injections may not be enough, or they may have a recurrence of their symptoms several hours later. So what we're seeing now, not just with food allergy, but with every disease, when people are having more of a problem, they're reluctant to go to the emergency department because they have a fear of getting exposed to COVID-19. If I go into the ambulance, does the paramedic that's treating me, they might be asymptomatic and have COVID-19, or the people that check you in the emergency room. So what we decided is to try and come up with an algorithm to try and work with patients and their physicians, keep them out of the emergency room if appropriate. So the first thing that we tell patients, of course, is talk to your physician, your allergist, and make sure that this plan is good for you. And it's also going to vary depending upon where you live. If you're in New York City, this would be a much more important algorithm to use rather than a small town in South Dakota, for example. So again, same paradigm. If you start having symptoms, shortness of breath, abdominal pain, nausea, vomiting, lightheadedness, or rash, inject the epinephrine. Next step is if you have a roommate or a neighbor, call them and leave your door unlocked or open and sit by that door. So if you have more of a problem, they can easily access the house. If those symptoms go away, that would be great. If not, within 5 minutes, you should probably inject another dose of epinephrine and then follow the algorithmic approach that we publish that basically says, look, if you have, after 2 injections, still residual symptoms, not feeling well, get the activation of the emergency medical services by calling 911.
Terrific. That's really good advice. And should somebody have extra pins laying around the house right now? Should you contact your doctor and ask them, just in case, because I don't want to be going out in this, can I get an extra prescription or two? Is that possible?
Yeah, so every one of the injectable epinephrines now come in a 2-pack, so you're able to give yourself 2 doses. In the best of all worlds, we'd like people to have 4 because what we know is that, number one, 2 may not be enough, and we don't know how long it would take for paramedics to get to you. And the second would be some people have a recurrence of the symptoms several hours later, so you have access to epinephrine in case that happens.
Terrific. And it sounds like even beyond COVID-19, the pandemic, maybe you ought to let a couple neighbors, if someone has this allergy, let a few neighbors know, I suffer from this. So if I call at a weird time, please answer my call, or just know that this is an issue for me, so that those people know in advance, the roommate knows or a friend knows, so that they can help you even more quickly than if nobody knows.
Absolutely correct. And the one thing that we're always concerned with is you could have a profound drop in your blood pressure where you pass out. And it would be nice have your spouse or your roommate or whoever capable of knowing how to use that epinephrine auto-injector so they can give you a dose while the paramedics are responding.
Great. We spoke with Dr. Courier, who's a psychiatrist here at USF Health, and he recommended that at the beginning of COVID-19 and throughout, that people, they're home right now and we're spending a lot more time at home. Sit down and get your medical records together. Sit down and get an emergency plan together so that when it comes time to need that, whether it's this month or 6 years from now, you have those emergency numbers and that emergency plan together. You just grab it out of the counter drawer and go forward.
Yeah, I mean, personally, I have mine on my iWatch. So, I have all my medications, medical history. They could access from my phone, my watch, whatever. But that's a great suggestion.
Yeah, that's a terrific suggestion too, to put it there too as well. So that's good. So we've talked a little bit about it, but food allergy sufferers are concerned about going to the emergency room. So we've talked a little bit about some of the things they can do. Do you have any further recommendations besides the epinephrine, if there's something else that they can do rather than go to the emergency room?
Yeah, I mean, we tell patients they should take an oral antihistamine right after they inject the epinephrine. If they're having breathing problems and they have a history of asthma, for example, they might want to use their rescue inhaler right away as well. Still, epinephrine is the main treatment, but it's good to have those other options available to treat other symptoms or perhaps quell the symptoms that you have a little bit more.
Okay. This paper that we've been talking about here with Dr. Casale puts emphasis on contacting your allergist and planning during the pandemic. We've talked a little bit about that, especially if you have severe anaphylaxis. That word just does not roll off the tongue for me. Anaphylaxis.
Yeah. Anaphylaxis. There you go. And it's a simple word. Phylaxis means prophylaxis or prevention. So the way this came about is in the early 1900s, French scientist that was trying to induce protection against sea anemones, and he injected the venom, and he had a severe reaction. So anaphylaxis is opposite of protection.
Oh, you learn something new every day.
There you go.
So is there anything more that you would recommend in this area than what we've talked about?
Sure. I think what we're seeing is people with food allergies are having more problems now because, you go to the grocery store and what do you see? Empty shelves. So it's very hard for people that have multiple food allergies to find foods as it is. Now, with the shortage of so many different things, they may not be able to find things that are free of the foods that they're allergic to. That's compounded if they decide to avail themselves of a virtual shopper, right? So they put down what they want, and the shopper may or may not contact you and say, they didn't have this, I'm going to substitute this. Well, our patients are very used to picking up the can, the bottle, looking at the contents, making sure it doesn't have peanuts, nuts, or whatever. Virtual shoppers are not, and they may substitute things that are potentially harmful for those patients. And then finally, the other place where you're going to see this is every time you go to a restaurant now, what does the server ask you? Do you have any food allergies? Now when you call for food to pick up, nobody's asking you, right? So that cross-contamination when people are cooking food and the ability to separate foods and cutlery so you don't contaminate somebody's food with something that they're allergic to. It produces a big burden. And then the final thing I would say is that people with food allergies, because they're trying to avoid these foods, they wind up spending a lot more on groceries. So now, if you have a shortage of food, don't have a job anymore, and you're strapped for cash, it's much harder to be able to afford to feed your family. And food banks are struggling as well to find allergen-free foods for people that might be afflicted.
Wow, that's not a good mix. So a lot of adults, we're going to talk a little bit more about this, and then I want to talk to you a little bit about your research. A lot of adults are suffering from late onset allergies. Like maybe I ate peanut butter all my life. I have a friend that ate peanut butter all of her life, and in her 40s, she ate a peanut butter sandwich, got hives, had an allergic reaction, went to the doctor, and the doctor said, "Oh, you're allergic to peanuts." And she was like, "Since when?" So, why is that happening, and are there ways to prevent food allergies?
Yeah, I think what we're seeing is a big uptick in food allergies in general, regardless of the age group. Obviously, kids are in young children are affected a lot more. So you see it very early on with milk and egg allergy. Fortunately, a fair percentage of those people outgrow it when they hit 3, 4, 5 years old or even older. The problem with things like peanut or tree nut is you tend not to outgrow it. I mean, it can happen, but you're much more likely to have that lifelong. And we're also seeing, as you pointed out, people that are developing food allergies in adulthood. We're not exactly sure why that is, but it tends to be lifelong. So it's a real problem for those people. I think the biggest thing that we're seeing now, though, is based on some research that FAIR helped sponsor, a study called the LEAP study published in New England Journal 5 years ago, where we learned a lot about prevention of food allergies in the very young. So when I was training 100 years ago, because I'm old, there was, we would tell people, don't introduce these baby, feed them milk and da 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 da, right? So it turned out that when epidemiologists and allergists were looking at peanut allergy, he said, wait a second, we have a whole bunch of peanut allergy in places like the United States, United Kingdom, but there aren't any in Israel. Why is that? Because the very young babies in Israel get fed something called bamba, which is a peanut containing chip. So these guys in the UK, they did an experiment where they took very young, high-risk infants, fed them peanuts, and what they found is that they prevented the development of peanut allergy. So now if you look at the American Academy of Pediatrics and the allergy organizations, the recommendation is that you feed your infant breast milk for the first 3 to 4 months, but you should really start supplementing them under supervision of a physician, foods that are high likelihood to cause allergies in the future. And we're hoping that that will help prevent the development of food allergy.
That's really interesting. I can't wait for my next conversation with the pediatrician to ask him about that as well. That's really, really
Right.
interesting and great advice too. So let's talk a little bit about how COVID-19 is impacting food allergy research and clinical trials.
Well, across the board, COVID-19 is affecting all clinical trials, unless you're doing a COVID-19 clinical trial. But all of our studies, and I'm involved in about 20 different studies right now, they're all sort of put on hold for recruitment of new patients. And the patients that are already in the studies, we're trying to do as many visits as possible virtually. So it's really a big change from what we were doing before.
Makes sense. So you just started some research or you're involved in research here with NYU, Northwestern, and Stanford on whether allergic diseases associated with something like COVID-19. Can you explain your research and talk a little bit more about what you're doing?
Yeah, so it turns out that when you have COVID-19 and you have a very severe course, you get what's called a cytokine storm. So you essentially the inflammatory cells release these molecules called cytokines, and they're what really cause the damage. They give you the fever, the headache, the destruction in the airways, and provide all of the molecules that give you the bad symptoms in course. Now, the immune system is complex, but that part of the immune system is different than what you would get with a traditional allergy. And it turns out what we're interested in is whether or not, if you have allergy, because you have an overexuberant response in that particular pathway, you might be protected against COVID-19 from either having more serious infection or perhaps symptoms at all. So we're going to be screening a bunch of electronic health records and databases to explore that possibility.
And this is research that you've just started doing based around COVID-19.
Yep. And, that may give us a hint on how better to skew the immune system packet to either prevent or to treat symptoms acutely.
Wow. USF Health has started doing telehealth and amped it up really quick during COVID-19 here in the last 6-7 weeks. Is that something that you're also doing for patients? And have you found it to be helpful?
Yeah, I think patients are getting a lot more telehealth visits. And as I said, for clinical trials now, that's what we're doing as well. I can't help but think that the way we practice medicine and the way we do things in our lives are going to be a lot different after this pandemic, even once we get it under control.
Yeah, I've been really impressed with physicians that I've worked with on these Facebook Lives doing the Blue Jean calls or Zoom or Teams, because I originally was like, I hope that they're going to know how to log in, but every single person logs in without a hitch.
Right.
And so they're all used to doing them. So they're like, no problem. Yeah, I know how to do that. Not a problem. Just send me the link. I'm like, okay, so perfect. Well, is there anything else that you want to add? It's been such a pleasure talking to you.
Oh, I appreciate it. I would just encourage everybody, no matter what disease they have, to make sure that they do have an emergency plan if they have an exacerbation of their particular disease. Make sure that they have enough medications so they don't run out, because now it's harder to get to the pharmacies, etc. And to just stay safe, practice social distancing, use gloves, use masks, and try and avoid situations that will put you at risk.
That's really good advice. Really, really good advice. Let me ask you one more question, if you don't mind. Let's talk a little bit about organic food, because a lot of people want people to be eating organic food. They find it's better for them. What are some low-cost alternatives for people that want to eat organic but can't necessarily afford the prices of some of the organic food?
Yeah, that's a good question. I mean, we talk about this in food allergy patients. It really doesn't matter, right? It's the content of that food. Whether organically grown food is healthier for you, I guess, people would argue one way or another, because sure, they're sprayed with herbicides, pesticides, and things like that, but there haven't been any big epidemiology studies that suggest that they're really bad for you. I think a lot of this is comfort level. People like, I don't want to eat meat. I don't want to eat things that are sprayed with pesticides and herbicides, and that's all understandable, but I don't think there's a huge health risk involved in not eating organic foods.
Wow, I'm really glad I asked you that question. That was a great response. Thank you again for your time today. We appreciate you joining us. We hope you'll come back on another Facebook Live with us.
Be happy to do that. Thanks, Michelle. Stay safe.
You too.